Yes. So Manoj, can we just start off the introductory remarks and the introduction? People
Yeah,
will
yeah,
just
yeah.
join in by the time Dr. Mamta starts.
Yes, I think so. Already, so many have joined. No? So, hello everyone. Welcome to the next lecture in the discussion series and all about sepsis. I'm so happy and privileged to see this course and meeting its ground objective of, uh, clearing the various concepts in sepsis. And ultimately, that is what is going to make the difference at the ground level. So we will continue with today's the session on viral infections and more. So to moderate today's session, we have Dr. Nelby George and Dr. Pavna. As you know, today's faculty is Dr. Mamta Jaju. Over to the moderators. Let's start.
Thank you, sir. First of all, I would like to thank Sridhar sir and for the great effort they have put to put Manoj sir's dream project, dream action plan in place. And we have great orator, Dr. Mamta Jaju, who is professor and in charge. And hopefully, he will enlighten us about the viral infection and to enlighten us to think beyond bacterial infection in neonatology. And over to Madam for the great talk. Madam has already said it's a long talk, so I won't waste much time. Straight, we will move ahead to the talk. I welcome you, Madam.
Thank you. Thank you so much. So I'm sharing my presentation. Am I audible?
Yes, Madam.
Yes,
Yeah.
Dr. Mamta.
Thank you, sir. So good evening, everyone. And good evening, Dr. Manoj, Dr. Sridhar, Dr. Abhay, and all the moderators. So thank you so much, NNF India, for giving me this opportunity to speak for such a wonderful module. I think everyone is liking it so much, and the speakers were wonderful till date. I hope I'll also do the justice for the same. Good evening, all participants. I'll start my presentation. So we all know that if we talk about bacterial sepsis in units, we always talk about when we talk about the sepsis in units, we always talk about the bacterial sepsis. So very less we think of that it could be a viral sepsis in units. So there are some issues that we need to discuss, that why we are not thinking of the viral infections, or why we are not focusing too much on viral infections. But you need to understand that viral infections, their incidence is very high. It's just 6 to 8% of live births. I think it's higher than the bacterial infections, but the problem is that we were not able to diagnose them properly. And it is one of the major cause of mortality and morbidity, not in the neonatal age, but in the fetus also. It is also a very important cause of poor neurodevelopmental outcome. And the most of the neonates, those who survive after the neonatal age, they have neurodevelopmental sequelae also. And the neonates are prone to viral infections, not only from in the extrauterine life, but in the intrauterine life when they are developing. So keeping all these things in our mind, that the viral infections are so common, it is very important to make a specific diagnosis and the early diagnosis. So for that, there are again some problems that why will you not be able to make the diagnosis, because we don't have the much facility available to diagnose them. But specific diagnosis is very important, because there are new antiviral drugs available to us. There are many vaccines which are available, which are preventing. Many immunoglobulins are available if we know the right diagnosis, which can help them in our fetus and the pregnancy and the postnatal life. And I think the most important thing is that we should need strong clinical suspicion to diagnose this, because that is what lacking in our area many times, because the first differential diagnosis we always think of is bacterial infection. So keep coming to forward. That's why we need to make a specific viral diagnosis for this. So we all know that there are different time of acquisition for the viral infections. It could occur, the most of them are occur in the prenatal and the perinatal life, and some of them are that in the postnatal life. So out of the infections, various viral infections, the few occur in the all three stages. They are in the perinatal also, prenatal also, the postnatal also, but their effects on the fetus and the just after birth life are different than this. So cytomegalovirus, if we see, so the common viral infections which are there in the cytomegalovirus, we see varicella zoster, rubella, herpes simplex is very common, HIV also, hepatitis B is very, very common. And in the postnatal period, we see enteroviruses, RSV, adenoviruses, influenzas commonly in the postnatal age, but not able to diagnose many times. So if we see through the acquisition, there are many viruses, their acquisition is different. So why we want to know? Because as I already said, that the mortality and morbidity is very high. But if we see the various stages that when they present, so if the infection occurs through mother in the congenital phase or the placenta, the fetus might be asymptomatic, might have abortions or stillbirths or hydrops can occur. They have multiple congenital malformations and they have late consequences also, clinical infections also. Sometimes the neonates, they are asymptomatic, but sometimes they are very severe infections in their life, and that severe infection can lead to either death or neurodevelopmental sequelae, as I already said. And the postnatal age, most of the time they present with sepsis-like illness. So it's a common mimic for the bacterial infections also, like enteritis, pneumonia, encephalopathy. So it is very important for us to know that what time the viral infection has occurred and what could be the consequences for the. So how we'll able to diagnose that? That diagnosis is important. The first most important thing comes when it comes to the diagnosis is history in the mother. Set like history, what is the age of the mother? What was the previous pregnancies like? Was there any sort of infection in the first trimester? What type of infection was there? What vaccines mother has received, or any other baby with this any illnesses is there. So there are many things which can guide us towards the diagnosis when we'll take the proper history in the mother. Then antenatal ultrasound is very, very useful because many of the congenital infections, they can have antenatally, if properly done ultrasound, they can show many few changes in the ultrasound in the fetus, which can suggest us for the infection. Then we commonly go for the torch serology. We know that torch is the few congenital infections, but now the list has increased. So nowadays, not properly the torch word will use for these. There are few infections which included in the torch, but there are many more which are there in the, if we go for the acronyms or terminologies. But here we commonly go for the torch serology. But usually nowadays, the torch serology has not a much role if we see in the mother also, because the IgG level of the mother reflects normally the maternal status. But if the specific IgM antibodies are present, they also have the different specificity and sensitivity. So it's not very useful except in few conditions. Then history in neonate is very, very important, that how the neonate has presented, what are the clinical presentations, was the baby was very sick, was there any risk factors for bacterial sepsis, was there any cause for IUGR if the baby is IUGR, or if the baby's presentation is like BPD, what was the cause? If we go for the physical examination, that gives us a lot of clue that what could be the cause for the infection. So mostly intrauterine growth retardation, microcephaly, sometimes hydrops fetalis, hepatosplenomegaly, pneumonia, bone lesions, typical rashes in different viral infections, and typical hematological anomalies are present in different type of infections. And to confirm that diagnosis, either in the antenatal period or postnatal period, we need PCR or histopathology of the placenta. So finally, what comes is that as clinician, we should have a strong high index of suspicion to diagnose these viral infections. So as I said you, the different viruses present with the different anomalies. So if we have commonly seeing the microcephaly, so few diagnoses comes like cytomegalovirus commonly presents with microcephaly, Zika virus commonly presents. If it is hydrocephalus or hydrocephalus, then B19 parvovirus is very common. Or if the intracranial calcifications are present, then cytomegalovirus, Zika are common. So with the different presentations in the baby, we should think that it could be a viral infection. So coming to the first viral infection, that is cytomegalovirus infection. So we all heard a lot about the cytomegalovirus virus. So it is the most common virus that causes the congenital infections. And this virus is important because it is the most common cause of sensory neural hearing loss and developmental delay in the neonate. So as much as that the 1/5 cause of sensory neural hearing loss could be because of the cytomegalovirus. So out of the total population affected with the sensory neural, 1/5 is because of the cytomegalo. And this virus belongs to the herpes family. And the typical characteristic of herpes family virus are they are latent virus. So they are present in the body, but they'll not show any infection, but suddenly with some immunocompromised state, some infection will occur. So it's very important that regarding the cytomegalovirus, and it can be transmitted through any infected saliva, breast milk, urine, or transplacental or blood and organ transplantation. So the more other important thing is that the seroprevalence is very high. So especially in Southeast Asia and the Indian countries, India, the seroprevalence is as high as 90%. So if we can see that in the pregnant women, if the seroprevalence is like they are exposed to this virus sometimes in their life. And if we see the characteristic pathology that it is a cytopathic virus. So what is that it affects mainly the cells of the body. So it stops the cell growth or mutate the cells in the fetal life, and destruction also occurs in the fetus. Other than that, it affects the endothelial cell lines of the blood vessels. So causes the blood vessel effect and decrease blood circulation through the placenta. And again, it decreases the cells and intrauterine growth retardation and multiple cells affected. So if some characteristic about the congenital CMV, we'll say only if the virus can be isolated or the positive PCR report within 3 weeks of birth. So after 3 weeks, if any CMV PCR is coming positive, it will not be labeled as congenital. It is most common, as I said, and prevalence is 1 to 5% in developing countries to 0.5 to 0.7% in developed countries. And in all live births, incidence is around 0.2 to 2.5. That is pretty high. And I already said you that it is the most common cause of sensory neural hearing loss. Developmental delay as much as 10%. So the transmission from mother to the baby occurs in the 3-way. It is either primary, reactivation, or reinfection. Primary, what do mean by the primary here is that mother is never exposed to this virus. So there was no seropositivity in the mother in any life. So almost 2% of the population, the women bearing age, are, especially in the Southeast Asia countries, they are seronegative. So the primary infection occurs in that condition through seronegativity. And the primary infection is as common as 40% of the pregnant women. If the virus infection has occurred or virus is there in the body, so it could lead to reactivation during the pregnancy, or reinfection with new strain could occur during the pregnancy. So that constitute about 0.5 to 2% of the total. So coming to next, that how does it affect? So as I said that the pregnant women, if we see that without CMV antibiotics, like primary infection is almost in the 1%. So 1% of this primary infection can lead to fetal. In fetal, it is around 30 to 40. It affects 30 to 40% of the fetus. And out of those 30 to 40% of the fetus, only 10% were symptomatic and 90% are asymptomatic. That is also a more problem for us if the neonate is presenting in the asymptomatic to us when the baby is presenting. Out of symptomatic, again, the sequelae are very common. So 90% of them, they have some sequelae in their life, and 10% became normal. And out of asymptomatic, 90 were normal and sequelae is 5 to 10%. So that 5 to 10% are problem, because in asymptomatic neonates, the sensory neural hearing loss is also very common. So almost 5 to 10% of asymptomatic neonates have sensory neural hearing loss. And if we see in those who have reactivation or the reinfection occurs, so out of the fetal infection occurs only maximum up to 2%, and symptomatic in 1%, asymptomatic in 99%. But again in symptomatic, it is very severe and sequelae are very common in 90%. And in asymptomatic, sequelae is very less. So if we see that even the asymptomatic congenital infection, they present late up to 2 or 3 years of age, and they have hearing loss is very common, seizures are very common, mental retardation are very, very common. But they can present with the acute fulminant infections, and usually congenital infection or primary infection, it presents with acute fulminant infection also. And mostly they have FGR, microcephaly, periventricular calcifications, cortical atrophy, chorioretinitis. So again comes that how to diagnose this CMV infection, because the most of the mothers, 90% of the mother, they are seropositive. They have already exposed to the virus, and the neonate are asymptomatic at birth in the 90% of the cases. So it's very difficult, and maternal serology, as I already said, is not very helpful. And the other findings, the clinical signs, sometimes they also evolve very late. So it's very, very difficult to diagnose CMV in the neonatal age also. And most of the babies, they are preterm also presenting with RDS, and most of the time we start treatment as we treat our preterms, but after sometimes like 2 to 3 weeks, if they are not improving, or thrombocytopenia is persisting, or anemia is persisting, blood cultures are coming negative again and again, then we need to. The second thing is, we can suspect congenital CMV in mother if we have maternal history of seroconversion or a mononucleosis-like illness in the pregnancy, or if the good ultrasound fetus has been done and which has shown some typical features present in the fetal cranial ultrasound of the body. One is ventriculomegaly. Ventricular calcifications are very, very common. If we see ventricular calcification, then the echogenic bowel is a very characteristic feature. They might have polyhydramnios, pleural effusion, pericardial effusion, intrahepatic calcification, present with pseudomeconium ileus and placental enlargement. So the second point is the fetal USG will be helped. And if the fetal USG shows some clinical suspicion of CMV, then we should counsel the mother, parents, and we should go for the amniocentesis at 20 weeks of the life to see that how much is fetus affected or what are the problems in the fetal. So it is very, very important to suspect CCMV in mother, but routine serology is not indicated. Then the second suspicion once the baby is born are the typical characteristic clinical signs which baby present. As I said, most of the time it is asymptomatic, but there are multi-system involvement also. And the most common, those who are infected, they present with the petechia or the purpura. Hepatosplenomegaly is very common. Jaundice is very common. Thrombocytopenia, blueberry muffin, typical rashes on their body. And about 30% have intrauterine growth restriction and microcephaly. If we see for the CNS, they have periventricular calcifications, ventriculomegaly, cortical malformations, and chorioretinitis. And sensory neural hearing loss occurs in 60% of the symptomatic and 5 to 10% of asymptomatic infants. So even if some newborn coming to our well baby clinic and after hearing screening, if we found that the hearing is not there, then in that case also we should go for the CMV PCR to diagnose that, because there are treatment available which have shown that if we start the treatment properly, then the sensory neural hearing loss will improve. So moving forward, so these are few indications for testing when we go for. So if we have seen that mother has history or ultrasound has some findings or CMV PCR amniocentesis is positive, then once the baby is born, we need to go for the CMV PCR of the baby also. So what are the diagnostic methods available? So one is PCR. which is from urine, saliva, blood, anywhere you can take, but urine PCR is the gold standard. So whenever we need to sample for this CMV, we should go for the urine PCR. Then spin enhanced or shell vial cultures are there, which are much more rapid, and virus can be detected with high sensitivity and specificity within 24 to 72 hours. But it is replaced by quantitative. Then negative test result generally rules out CMV infection, but sometimes they have acquired within the prior 2 to 3 weeks postnatally. Then it is not possible to detect with them in that time. CMV antigen is also a positive result confirm infection and viremia, but negative result do not rule out. So it has some of the false positivity. CMV infection, we go for the IgG, IgM, but it has very limited usefulness. So we should not go do any TOS titers in the neonates. And we should always go for the urine PCR. But a negative viral test from blood cannot rule out CMV infection. But a negative urine or saliva test in an untreated infant, symptomatic for weeks or more, does rule out. So if your urine PCR or saliva comes negative, then we are sure that it is not CMV. Other tests which we need to do in the babies, we look for the CBC, anemia, thrombocytopenia, leukopenia, LFT if increase in the transaminases level or bilirubin level or direct cholestasis is present. Then go for the USG or CT or MRI, which gives you the lot of changes in the brain which are there. So the key take message here is that we need to go with the maternal serology with paired IgG, IgG. I'll tell you, Abhi. Next in the next slide to confirm the primary CMV infection. Prenatal diagnosis relies on amniotic fluid PCR timed appropriately, and neonatal CMV diagnosis also depends on the PCR testing of urine saliva within 3 weeks after birth to label it as a congenital CMV. So this is a chart which shows that whenever you are suspecting congenital CMV through the antenatal testing, then perform CMV serology, IgG and IgM done in the mother. If it is negative, it suggests that there is no evidence of infection. But if it is positive, IgG is positive and IgM is negative, then again, it is not any infection, but mother has been exposed to the virus sometimes before. And if the CMV, IgG and IgM both are positive, then we need to do the avidity also. So avidity normally they do with the TORS serology. If IgM, IgG avidity is positive and avidity is low, then it suggests the recent infection within past 3 months. If IgM, IgG avidity is intermediate, suggestive of, this also suggests of the recent infection. So as I said, go for the amniocentesis. A proper counseling of the parents is required. And if the baby is amniotic fluid CMV PCR negative, so infant is not infected, so can continue with this. And if it is positive infected, then you need to follow up with the ultrasounds every 2 to 4 weeks, or sometimes it requires fetal MRI also to know the this. So it requires the prognostication, proper counseling, or sometimes termination of the pregnancy also if the fetus is the lot of complications are present in the fetus. So you need to divide it. Either it is asymptomatic, good prognosis, residual risk of hearing loss is there, mild or moderately symptomatic, or prognosis is uncertain. But again, question comes that how many times we are doing it or how many times we are following. So now comes that it is important to do and make a timely diagnosis because we have treatment facility now. Good antiviral drugs are available which can treat these babies. So there are treatments which are available. So one is, we all know ganciclovir. It's intravenously used drug. And the new drug has come, which is ganciclovir. It is we can use it orally. So if the neonate is oral is allowed, then it is better to start with this. The doses are different. It is ganciclovir is 6 milligram per kg per dose 12 early, and ganciclovir is 16 milligram. So normally, initially it was said that the duration of 6 weeks were bad, but our recent trial has shown that the treatment, if done till 6 months of the age, will improves the hearing by 20 to 30%, and also the neurodevelopmental delay also shows to be improved. So now the treatment recommendation is for the up to 6 months, but we need to do the blood tests repeatedly to see the side effects, because side effects are very common. Neutropenia, they usually, the bone marrow affection is there, thrombocytopenia, anemia, renal dysfunction, and teratogenic potentials are there. With the treatment, we need monitoring, and urine CMV viral load also to be done during the treatment. Follow-up is important in these patients because, as I said, that there are multiple systems involved. So hearing is very common. So after diagnosis, we need to do hearing every 3 to 6 months in first year. Even in the asymptomatic, if it is positive, then we need to do hearing assessment till the age of 3 years. And if it is positive, till the age of 6 years. Ophthalmic assessment is also very important because choroidal retinitis is very common. And detailed neurodevelopmental assessment and with the as per the corrected gestational age is very, very important. So as I said before, that infant diagnosed with hearing loss by or failed audiology test, CMV PCR to be done. Then comes the postnatal CMV. It is in transmission is through the breast milk. Nosocomial also occurs through the seropositive blood products or urine, saliva, or the if the contaminant, some patient is there and the contamination occur. And mostly it is asymptomatic also. But in extreme preterms, we have seen like severe end organ disease or sepsis like syndrome involving the multiple organs, hepatitis, cholestasis, pneumonitis, neutropenia, thrombocytopenia. And CNS involvement and long-term developmental neurological abnormalities are common. CMV pneumonitis is very, very common, and mostly we keep on treating as the bacterial infection or the BPD-like picture, then until unless we have proven results of the this. Transfusion-acquired CMV is also very common. It usually followed by the transfusion symptoms 4 to 12 weeks after transfusion symptoms develop and last for 2 to 3 weeks and consist of respiratory distress, pallor, and murmur might be there. So prevention is again very, very important. So as we know, there are till date few vaccines has gone phase 1 trial, but till date no vaccine is available. There are no approved vaccine. High dose of valacyclovir tried in mother has shown to reduce transmission, but still it is not approved till date to use in the antenatal period. Then comes to the most important thing is the hygiene. So how the mothers who are exposed to the toddlers, babies, or the small babies, or they are working in the schools or where the crash the babies are there, so they will be emphasized to do hand washing. Then pregnant women should avoid sharing any food, drink, cutlery, dummies, or kissing the child where they are working because they are asymptomatic shedders and the high incidence are present if the baby is living there, because transmission occurs from one child to another. So washing hands after contact with urine or saliva of young child is very, very important. Breast milk safe in term baby. So in preterm baby, they advise to do the freezing and then give it. The pasteurization is not advised in the preterm milk, but for the blood products, this has reduced a lot the transmission because of the use of the leuko-reduced blood products or radiation, which is decreasing the CMV transmission. So the next comes another very important infection, which is herpes simplex virus. So we'll go for the various modes of transmission and risk factors. Clinical spectrum, how will you confirm? Can we differentiate between the primary or the non-primary episodes? What would be the management and how would the baby's management have differed if it is primary maternal infection? So again, coming to the herpes, it is also of the same class with the cytomegalovirus, though there are two herpes simplex virus which usually cause HSV. So one is HSV1 and the 2, both are double stranded enveloped DNA viruses. Again, they have the tendency to have the latency and causes lifelong infection. So classically or histologically, the HSV1 is above the belt, so it causes the oral and the other area. HSV2 is below the belt, is the mainly genital infection. But now over a period, it has changed. The HSV1 also causes many of the genital infections. So the transmission is same. The perinatal is very high, 85 to 90%. And mostly the areas where the baby's body touches the maternal, during the delivery, vaginal secretions, where the vesicles appear. Intrauterine is very, very rare, and postnatal can occur in almost 10%. So majority of genital infections are asymptomatic, but 30 to 50% with primary infections and 0 to 3% with recurrent infection at the time of vaginal delivery, the herpes can occur. And despite that, the many of the pregnant, the again important thing here is the many of the pregnant women, they don't have any sign and symptoms of herpes infection. They are asymptomatic shedders, and the infection occurs during the pregnancy. So then again, it creates the dilemma that should we see for this. So this is the serology. If we go for the serology in the mother, if we see the type of maternal infection, HSV PCR culture, and 1 and 2. So if it is a primary infection, then the either of both positive, HSV1 or can be positive. But if we see for the antibodies, both can be negative because it has been transmitted a new infection. In non-primary infection, it is HSV1 or HSV2, both can be positive, then in antibody, one will be. If it is recurrent infection, then we'll see that HSV1, 2, any can be positive. But if it is 1 is positive, then in the recurrent, the antibody for the 1, IgG for the 1 is positive. And if it is 2, then 2 will be 1. So it might help us in some interpretation if we see for the serology in the PCR culture. The main infections are primary maternal infection late in pregnancy. If it is there, then it will. Prolonged rupture of membranes, if it is there, then it can increase. Mode of delivery, either cesarean or vaginal. Invasive fetal scalp electrodes. If there is co-infection with maternal HIV, then herpes increases. Asymptomatic viral shedding is very, very common. So clinical features, again, the classic trial is skin lesions, chorioretinitis and keratoconjunctivitis, and microcephaly, rarely hepatomegaly and cytopenia due to HLH-like presentation. So clinical congenital HSV is very common. But in the neonatal herpes, if we see, so there are 3 types of presentation in the neonatal herpes. The important thing is to again diagnose them early, because if we diagnose and start treatment early, because we have a sure 100% treatment available for the herpes, so treatment will really change their outcome, decreases the mortality and the severity of the disease. The first presentation which commonly occurs is the skin eye mouth disease. It is most common, 45%. It usually presents in 1 to 2 weeks of life, and there are clustering of vesicular lesions with erythematous base mostly on presenting parts. So the typical herpetic lesions we all know. There could be eye, watery eye, conjunctival erythema, or mucosal localized ulcers present. Outcome is very favorable with treatment in this. The another group is disseminated herpes, which is present in 20 to 25%, and its presentation is typical like sepsis-like syndrome. So the common bacterial sepsis also presents like this, and severe sepsis. So it has multiple organ involvement, and mortality is very, very high if untreated. And the third group is the CNS involvement, like encephalitis. It presents in 35% of cases, presents usually in 2nd to 3rd week of life. Usually 3rd week. Common features are encephalitis, seizures, lethargy, irritability, poor feeding. And mortality, even with treatment, is 15%. Without treatment, it's very high. So the point comes here that should we start treatment empirically or not in this? We'll discuss it further. So the diagnosis first need that we need to have suspicion that it could be a viral herpes viral infection. Maybe the history is not present in the mother, or mother is asymptomatic shredder. Then also if the baby is present in the 2nd week of life or have some vesicles or sepsis-like infection, then we can think that it could be a herpes infection. Viral cultures definitive is diagnostic from any surface like blood, conjunctiva, respiratory secretions. PCR also gives you the very good result, but negative PCR from CSF could be false in early stage. CSF is very, very important, especially CSF PCR also we do. And if the lymphocytosis with red blood cells or normal or high protein with normal glucose are present, we can think of CSF herpes infection. Liver function shows raised transaminases or to fulminant. Eye examination, keratoconjunctivitis is there. EG and MRI are very, very important in neonatal herpes, especially if it is the CNS, because it involves the temporal lobe. There are brain edema, hemorrhages, or destructive lesions are present. And EG shows typical multifocal discharges from frontotemporal lobe. So the idea is that even if we are suspecting it, we can send the samples and start the treatment as we are doing in the bacterial sepsis. So it is better if we are highly suspecting that it could be a viral infection or herpes infection, and we are not getting any clue for the bacterial infection, that what could be the risk factors for the bacterial infection, then in that case, it is better to start for the treatment. And treatment of choice, we all know, is acyclovir. Selective inhibitor, it acts by the selectively inhibiting the virus. Asymptomatic and high risk of exposure, it has to be used in the very high doses, 20 milligram per kg, 8 early, total 60 milligram dose in neonate per day. And if it is asymptomatic or the SCM only, it is for the 14 days. If it is CNS disorder or disseminated, we need to use it for 21 days. Send repeat CSF PCR after 21 days. If it is positive, PCR is positive for virus, then continue for 7 days or till PCR is negative. We need to monitor for the side effects like renal function test and etc. Neonatal ophthalmic herpes is very common. So here we need to give the antiviral local agent with IV acyclovir. And it is also said if it is neonatal herpes disseminated, or as I said, it is very latent. So suppressive therapy is indicated, where you need to get 300 milligram per meter square dose 3 times a day for 6 months, and need to monitor on the therapy. So, so flow chart just showing that how to evaluate if the mother is having genital herpes and the baby born is asymptomatic, then we need to evaluate that newborn after 24 hours. First, because 24 hours is recommended, because to differentiate between the contamination of the neonatal skin by maternal secretions versus true herpes simplex virus infections. So what we'll do, we take the surface swab for viral cultures, our DNA PCR, also the liver enzymes, and initiate the parenteral acyclovir with 60 milligram per kg per day. HSV disease in the newborn, if it is present, then treat for the CNS or the infection for 21 days. If it is not, the HSV CSF is negative and normal ALT, then give for 10 days. Or if surface swab or blood is negative after 24 hours, then no evidence of HSV infection, only follow-up is required. So this is very important where the mother is having the genital herpes infection, how to follow these babies. Prevention again, symptomatic mother, then give oral or IV acyclovir. Cesarean section, if active labor, lesions are present at labor. Otherwise, there is no indication of cesarean section. Oral acyclovir from 36 weeks, if the mother is having history of recurrent HSV, then avoid scalp electrodes. Breastfeeding should be continued until there are active breast lesions are there. And education of mothers are always very important for these type of infections. Outcome, disseminated without treatment, mortality is very high. With treatment, reduced to 29%. CNS also reduced to 4%. From without treatment, it was 50%. And SEM also have very less mortality. So keep high index of suspicion with sepsis-like illness or encephalopathy after 7 days of life, and start acyclovir after sending viral cultures and PCR. Another very important is the same group of viruses, varicella zoster virus. It is also herpes virus related. It causes primary infection is chickenpox, reactivation is zoster, and older patients may develop post-herpetic neuralgia also. So susceptible pregnant women with varicella, lack of maternal history or vaccination, exposure to infected contacts, airborne or contact with lesions or in maternity womb, and maternal shingles if rarely causes neonatal disease unless rash disseminates. So congenital varicella, though it's very less common, but it transmits from mother in first to second trimester, and it is a very severe infection. It causes limb hypoplasia, scarring, and dermatomal patterns typical you'll see on the skin. Cutaneous cicatrice or skin scarring is there, microophthalmia is there, chorioretinitis, cortical atrophy, and low birth weight. So it's a very, very severe type of infection if it is congenital. But if it is neonatal varicella, it is most common. It is high. The most common is because the infection occurs usually 5 days before to 2 days after delivery, and typically presents 10 to 14 days after birth with fever and rash. The typical vesicular rashes present, sometimes babies having pneumonia, hepatitis, thrombocytopenia, and DIC. Mortality can be very high if the not diagnosed properly or not started on the treatment because of the pneumonia and other dissemination. And postnatal varicella is also there. It is more than 1 month. So again, the diagnosis is maternal history of rash, serology. But here, if the varicella zoster immunoglobulin has a role, if history of recent infection in the mother, IgM in the mother recent infection, PCR or culture of vesicular fluid is positive, or infant with skin lesions or exposed neonate should have varicella zoster testing if available. Or clinical is very good because clinically we can make that it is varicella zoster infection. PCR or culture of vesicular fluid should be done if it is possible. Infant with skin lesions or skin should have varicella zoster or testing if available. Again, the treatment should be start in the neonates with acyclovir and as early to reduce complication as possible. Supportive care is again very important to prevent secondary bacterial infections and to maintain the fluid and the prevention. Before pregnancy, confirm the maternal immunity. If mother has received the vaccine or not, avoid pregnant. If the mother has received pregnancy or vaccination is done in the just after marriage or then you need to avoid the pregnancy for 1 month. Vaccine is contraindicated during pregnancy. If babies, the peripartum exposure has occurred and varicella zoster immunoglobulin within 96 hours we need to give. Maximum we can give it up till 10 days of the life to pregnant women and neonates both. Dose is 125 international unit. If it is not available varicella, then IVIG can be used as 400 milligram per kg. It should be given immediately to neonates born to the mother with rash from 5 days before to 2 days after delivery, if unavailable. So if vaccination is not done in mother and mother is having active herpetic lesion or the baby can be transmitted to baby, then we can give the varicella zoster immunoglobulin. Then come another very, very important infection, hepatitis B, because of the high incidence of the hepatitis B in the population. So globally, around 240 million people are having positive for the hepatitis B. Perinatal transmission is the main route, especially if it is HBs positive or HBe-Ag positive. Vertical transmission also occurs in 50% of chronic hepatitis B virus. In India, the prevalence is 1 to 9%. The range is very high. Transmission occurs through the percutaneous permucosal routes from infected blood, either through vaginal or C-section, wherever the blood is exposed to blood. Active maternal infection in late pregnancy. If no prophylaxis is given, transmission is around 90%, and less than 4% is transplacenta. So it is very important to, like most of the neonates are asymptomatic at birth, but they will progress to chronic infections like cirrhosis, hepatocellular carcinoma, and etc. So in all the mothers during the pregnancy, HBsAg should be done in all the mother. But how there are different levels we can show. The HBsAg, if it is positive, it indicates the current infection. If anti-HBsAg indicates the immunity, post-vaccination or resolved infection. Anti-HBC, core IgM marker of recent infection. HBe antigen indicates a high infectivity. And if HBsAg more than 6 months it is positive, then we can label the chronic infection. So in all the mothers who are pregnant during the first trimester, HBsAg should be done. Because if it is diagnosed properly, we can protect the baby with the immunoprophylaxis. All pregnant mothers should be screened positive and viral load is high during the 20 to 30 weeks of gestation. Or if it is viral load is more than 200,000 IU per ml during third trimester, then maternal antiviral therapies also can be started with tenofovir prophylaxis in the mother. Neonatal prevention, we all know that if the mother is AG positive, then within 12 hours of birth, we need to do the active and the passive immunization both. Active is through giving the hepatitis B vaccination, and passive is with the hepatitis B immunoglobulin 100 international unit. It prevents more than 95% of transmission. But if the baby has received the 0 dose or within 12 hours, the first dose, we need to follow the universal immunization as 0, 1, and 6 or 0, 1, 2. But if it is preterm baby less than 200 grams, then or mother is HBsAg positive, then we need to give one more extra dose. So first dose will not be counted in the routine immunization. We have to go for the 6, 10, and the 14 weeks. How we will follow? So risk infants will do HBsAg and anti-HBs levels. If HBsAg is negative and anti-HBs is more than 10, then the baby is protected and vaccine responder. If it is HBsAg positive and anti-HBs less than 10 international unit, then vaccine non-responder or infection or revaccination further are required. If it is HBsAg positive, then infected and we need to do the close follow-up. Breast milk need to continue, though the postnatal viral transmission occurs through the breast milk. But if the HBIAG has been given and hepatitis vaccine has been received to the baby, then the transmission will be reduced. So continue with seeing the effect that in the developing world, we need to continue with the breast milk. The second most important virus which is causing hepatitis, chronic hepatitis or hepatocellular carcinoma is hepatitis C. Again, 71 million people are affected with the hepatitis C, and it is major cause of chronic hepatitis. The drug abusers, chronic injection use, transfusion recipients, dialysis patients, they are prone for the hepatitis C infections. Vertical transmission is 5%, perinatal is mainly 50%, intrauterine 30%. Breast milk, it's very rare through breast milk. High maternal viral load at delivery, high maternal liver enzymes 12 months before pregnancy, rupture of membranes more than 6 hours, prolonged or difficult deliveries, concomitant HIV infection, invasive fetal monitoring. This all are high risk risk factors for the transmission. Diagnosis again is by HCV RNA. Marker of infection if found for 2 or more times. Diagnosed by anti-HCV antibody also, but anti-HCV antibody is not recommended in infancy because of presence of passive transfer of maternal antibody. Treatment, antiviral drugs are available, few, alpha interferon and ribavirin. All mothers should be screened again for HCV. Avoid invasive obstetric procedure, fetal scalp monitoring, chronic screen blood for before use, and breastfeeding should be again continued, except in case of cracked nipples where it can go through the blood also. So antiviral treatments, which are few of the new antivirals are also available, which are very, very costly drugs, around $1,200 for one, is not routinely available also in India. Another is rubella virus. It is, we know all that rubella vaccine is available, and it is also called German measles, transmitted by respiratory droplets. We know vaccine is available, and the countries where vaccines coverage is good, the reported incidence has reduced to minimum, especially in US and other countries, but still in our country, though government is taking a lot of efforts to improving the rubella vaccination, MR campaigns are going on, but still the immunization in adolescent girls are very, very high. Transplacental transmission is very high, especially in the first trimester, and if it is there, then 90% of the fetus will get affected. And the clinical presentation, the baby fetus affection was very severe in the rubella syndrome. We all know that sensorineural hearing loss is present. They have congenital heart disease, cataract are very common, microcephaly, mental retardation, developmental delay, hepatosplenomegaly, thrombocytopenia, blueberry muffin rush, fetal growth retardation are very common. So the especially we need to look for the triad in the congenital rubella with the deafness, heart disease, and the ocular abnormalities. Diagnosis again comes with the clinical suspicion and maternal history. Neonatal IgM positive for rubella virus, rubella PCR from blood, urine, or throat swab, or low IgG avidity in mother suggests the recent infection. The prevention is mainly through the MMR vaccine, we know, or MR vaccine, MR campaign, which is there, which is going on at 9 months also, during adolescence also. And even if the married girl, if she is not vaccinated, she can receive one dose 3 months before the pregnancy. As there are no antiviral treatment available for this, so the most important thing is that we should go for the immunization as much as possible in the female child. Follow-up is very, very important. Multidisciplinary follow-up is because hearing, vision, cardiac, everything is involved in this, and psychosocial support for the long-term disabilities. So it is a vaccine preventable disease. So our focus should be on that, how we can counsel and encourage everyone, the adolescent girl who is coming in our contact, to make them vaccinated, like tell them to vaccinate for this, because it has a lifelong impact also. HIV again, as we all know, is if it occurs in the baby, it is very severe. Is a retrovirus, HIV 1 and 2. It targets the CD4 cells, integrate into house, by reverse transcriptase. In India, around 22,000 per year pregnant women are HIV infected. Vertical transmission, mother to child transmission mainly it occurs. And if the mother is not, pregnant lady is not on any ART, transmission risk is very high. With ART and precautions, it is very low. So again, it is important to diagnose and to start on the ART treatment. In utero, transmission is around 25 to 30%. Peripartum is 50%, and by breastfeeding also it occurs to be 10 to 15%. Again, risk factors for transmission other than this are, if the HIV RNA copies are 52,000 per ml, risk is 1 to 2%. If HIV RNA copies are less than 50, risk is less than 50. If no ART is received during pregnancy, or prolonged rupture of membranes, vaginal delivery, high vaginal load, or mixed feeding practices if done, the transmission is very high. If no ART therapy has been given to mother and breastfeeding is done, then the transmission is at up to 45%. With no ART and no breastfeeding, it is 20 to 25%. And ART with breastfeeding, 2%. ART with breastfeeding, 1%. Sorry, if one is ART without breastfeeding is 2%. ART with breastfeeding is 1%. So we can see that the timely diagnosis, ART, start treatment in the mother and the treatment in the baby, both decreases the transmission to very less. So what is the treatment, the prevention we should start? So we should start all pregnant and breastfeeding women with the triple drug, that is tenofovir, lamivudine, and efavirenz is lifelong therapy, regardless of the CD4 count. What this guidelines in the India says. And normally, the mode of delivery should be LSCS, is not indicated. We have to go for if the mother is on the antiretroviral therapy, the normal delivery to be done. So the mother comes in the active labor and no ART was started, then should be given with all the 3 drugs. Prophylaxis in neonate should be started and continued up to 12 weeks. If diagnosed just before delivery, the mother comes in the active just before that in the delivery phase, then should be started and at least give 4 hours before the labor. Then neonatal management is again very important. So use universal precautions during delivery, resuscitation as per the NRP guidelines, delayed cord clamping need to be done. Alert ART center to start on the baby drugs with the baby. If the baby is asymptomatic, all birth doses of vaccine to be given and start with the nevirapine, continue for the 12 weeks. HIV 1 and 2 infection both are there, then start on the SFT. And if the viral load in mother is very high, then start on the 2 drugs in the baby also, then nevirapine and Azepti. If the baby is very sick, symptomatic, then start with the 3 drugs. And cotrimoxazole prophylaxis should be start. It should be start in the from 6 weeks to 6 months in HIV exposed infant. Need to do PCR at 6 months. And if it is negative at 6 months, then continue with the breastfeeding. And if not on breastfeeding, then stop the cotrimoxazole. DNA PCR to be done before 6 weeks. If it is positive, repeat test, start ART and continue cotrimoxazole also. DNA PCR negative, then stop nevirapine. Continue cotrimoxazole. At 6 months, repeat DNA PCR positive, start antiretroviral therapy, continue cotrimoxazole. Again at 18 months. Till 18 months, continue this and do HIV antibody at 18 months. Immunization, asymptomatic is routine immunization. If the baby is symptomatic at birth, then we will not give BCG. And other live vaccine, we need to see for the CD4 count, MR like measles, rubella. If it is CD4 count is more than 15%, then only we can give. Then Zika virus, though it is now, there was one epidemic occurred few years back in Brazil and then some places of India also. But again, it has a very serious effect on the fetus and the neonate. Mostly it is a neurotropic virus, so it affects the brain of the developing brain of the fetus. And the most important complications are the microcephaly, macular atrophy, intracranial calcification, ventriculomegaly, delayed myelination, and there was no antiviral treatment and only supportive treatment that we need to get. So vaccine again is under consideration, but still there are presently though no vaccine is available. The prevention is very, very difficult in these cases. So another is parvovirus infection. We all know, though we see the less, but it again needs strong suspicion. If the non-immune hydrops you are dealing with or severe anemia on day 1, day 2 of life without any other cause, you can think of the parvovirus infection. Again, vertical transmission in first trimester with higher viral load is 39%. Adverse outcome occurs in 7% of pregnancies. And before 20th week of gestation, fetal hydrops and death can occur in this. Diagnosis is again by the serological testing of both mother and infant. We can do viral PCR. DNA is the gold standard for the mother. And mother might have the history of the rash or illness in the present. And sometimes intrauterine blood transfusion can be done and is curative also. Supportive therapy, though no antiviral drug is available, but IVIG helps because it suppresses viral replication if infection is persistent. Prevention is most important. Hand washing, avoid exposure to suspected survival cases. And there are no vaccine available for this also. H1N1 we see, but it is mostly in the postnatal period. Droplet infection, if in the surroundings a mother or somebody is having, then treatment we all know is oseltamivir. We should get, if we highly suspected cases, we should get neonate tested for the H1N1 virus. If the presenting a preterm neonate or even the term neonate with the viral like pneumonia, so should go for the H1N1 testing. RSV is again very common, paramyxovirus family, highly contagious, mostly horizontal transmission. Viral cultures can be done. Clinical features may be asymptomatic, upper respiratory to severe like apnea or pneumonias, rhinorrhea. And high mortality sometimes occur if the underlying cardiac diseases or other complications are there in the baby or the other congenital malformations are there. So aerosolized ribavirin for high-risk newborn is the treatment. Another group is enterovirus. It is also a RNA virus. There are 4 types of group of viruses in this, out of which Coxsackie virus and ecoviruses are very, very common. Transmission is transplacental and it is life-threatening many times. So because it presents with the meningoencephalitis, myocarditis, sepsis-like illness, fulminant hepatic failure, mortality and morbid is very high with myocarditis. It is almost 50%, and sepsis-like illness almost present with the 100%. Difficult to differentiate with bacterial infections, so almost requires a very high index of suspicion. And especially if the outbreaks are occurring in the neonate, many of the neonates are going with 1 or 2 same problems in one neonate declared in the second and the third. So we need to think of the enteroviruses. Diagnosis by the viral cultures or PCR of viral cultures of the nose, throat, stool, blood, urine, and CSF, and treatment is mostly symptomatic and the supportive. So still there are few viral infections left, which is one of them is chikungunya, dengue viral infections. Though we see rarely, chikungunya is very common in our unit also. We have seen 3 cases in last few months. It's very common and mostly they are vector-borne diseases. The typical symptoms of chikungunya is fever, high grade, arthralgia, irritability, cry, decreased movements, and they have typical chick signs. Hyperpigmentation of the nose is present, and we can identify by seeing the baby that it is a chikungunya. And chikungunya is also sometimes very severe because it presents with the encephalitis in the neonate. The treatment again there is also symptomatic and the supportive, but diagnosis is very, very important. And follow-up is also important because encephalopathy and mental retardation occur. Dengue, again, dengue serology, we can diagnose. Mostly they have hemorrhagic like illness, DIC like picture, the petechia, purpura, and bleeding from many sides, and sometimes it's very sick. The neonate is very sick. So many of the viral infections, they are emerging, they are coming. We all need to have a strong suspicion, and we need to come out of the box from the bacteria. So always we think of it's bacterial infection, start antibiotic, high antibiotic, and increasing the multi-drug resistant. But we need to think of that it could be a viral or it could be a herpes-like illness or the enterovirus or any other things. So with that, I'm ending my presentation. Thank you so much. And now can open for the discussion.
Thank you, madam, for a very excellent talk. Actually, it's very difficult to cover this vast topic in such a short time. Thank you for touching everything. There are certain questions. Actually, somehow I can't see the chat box. I can see only the last question. I'll just start with that. For a baby with toxoplasma IgM, ELISA was positive and IgG is negative, and PCR was negative. IgM was done after 10 days. How to proceed further, madam? Hello? Hello? Can you hear me?
I can hear you. Actually, here we have covered only the viral infections, and toxoplasmosis is not from that group. So I've left that toxoplasmosis. So maybe we'll cover in some other lecture on the.
Yeah, it's better.
Yeah, because it's itself is a big topic to cover.
Viral itself is a lot of the things are there covered. Another next question, let me see. Most of the questions are regarding this CMV. The first question was, kindly explain the percentage of primary infection as well as reactivation of CMV and its effect on the fetus.
So I have already covered this in my presentation. So we know that I'll give you the exact percentage from the slides only. So this slide, where is that? So what they have asked is primary infection. It is on
as well as the reactivation.
Yeah, so primary infection is usually occurs in the 1% of the pregnant women. And out of those primary infection, 1%, the fetal infection are very, very common. So if the mother is infected first time, the fetal infection is around 30 to 40%. But if it is reactivation or reinfection, then the fetal infection is very less. It is up to 2%. And out of that 30 to 40% of fetal infection, only 10% are symptomatic. But that symptomatic infection causes a lot of sequelae and the fulminant infection also in neonates. So I think that's okay.
Yeah. Another question regarding CME is this CME and breast milk. How much time, the duration of freezing of breast milk?
So routinely, it is not advisable to freeze the breast milk because it will lose the property of the breast milk. So the literature, whatever available, it says that the freezing should not be done and it has to be given like that only.
Yes, madam. Another question was I couldn't see that question right now, but I have seen it. Well, which all babies, preterm babies has to be, the question was something like which all preterm babies has to be targeted for CMV screening in extreme preterm babies, and also how to proceed with these babies.
So there are three things which I said. If the mother is suspicion of any infection in the mother, if the mother is IgM, IgG positive with low avidity, which suggests recent infection. The second point is if any fetal ultrasound, the antenatal ultrasound, which shows any CNS involvement or the periventricular calcification, if it is there, then if these two are positive, then we should go for the amniocentesis at 20 weeks after counseling to see that the baby is affected or not. If it is there, so I'll show you the chart. If it is there, then we'll see what is the severity. Sometimes we need to go for the fetal MRI also. If it is amniotic fluid is negative, then nothing to be done. But if it is positive for CMV PCR, then we need to look for the fetal MRI or other chances and see it is mild or moderate or severe types. So sometimes if it is very severe, the counseling need to be done for the termination of pregnancy also.
Thank you, madam. Thank you, madam. Another is regarding this starting of acyclovir. Should it be started for asymptomatic babies born to mother with genital herpes? And if you are starting, how long should you?
So genital herpes, if mother, I have again showed that also. If the mother is having genital herpes and the baby is asymptomatic, we need to do the screening first at after 24 hours life. For PCR, HSV we need to see for the baby. If HSV PCR is positive, then we need to start on the treatment. CSF, HSV PCR positive, start treatment for 21 days. If it is negative, then it has to be give therapy for the 10 days, preemptive therapy for the 10 days.
One more question, madam. How to approach a baby born to mother with herpes zoster during pregnancy? I think you have one.
Varicella zoster.
Yeah.
Again,
Okay.
so if baby's symptom, if the infection has occurred in the mother 2 days before and 5 days after delivery, then baby need to give with the varicella zoster immunoglobulin and acyclovir need to be started on the baby.
I think we have covered almost all the questions. And thank you, madam, for covering this extensive topic in such a short time. Over to Abhi. Abhi?
Sridhar sir.
Sridhar sir?
Hi, yes. Thank you, Dr. Mamta. Yes, that was a very extensive and a very detailed explanation of viral diseases. As you mentioned, I think one of the things is that we don't suspect viral infections. That is the last thing when everything else fails and you're stuck with no diagnosis. We think of that in many instances, especially in enteroviruses and other acute viral illnesses, not the congenital infections. So that was very nice. So thank you, everybody. Thank you, Nelby. Thanks all the participants, attendees who stay back so late for every single session. So the next session is going to be, I think many people asked questions throughout the series on housekeeping and cleaning of the nursery, cleaning of equipment, etc. So the next session on Tuesday will be on decontamination and cleaning of equipment in the nursery, and the equipment. So please join on Tuesday. Thank you very much.
Thank you.
Thank you all. Thank you so much.
Thank you so much. Thank you.